Hello, everyone. Hello. Welcome back to another exciting episode here on Doctors Go Live with me, Nina Cheryl Khan, your host. And today we will be talking about harnessing POCUS in critical care. What is POCUS? That's what we're going to talk about today. Now, let us know if you are tuning in, where you're tuning in from, and how are you guys doing? And of course, let us know what you would love us to cover in future episodes of Dr. Go Live. Or better yet, let us know what you want to know in today's episode of harnessing POCUS in critical care. Now, if you share this video out, you also get to take part in our Doctors Go Live quiz happening right here at the end after the Q&A, where you get to win exciting prize. So all this is happening right here in Doctors Go Live with me and our special guest for today. Now, we all know that as medical emergencies unfold, every second counts. And traditional diagnostic methods that are time consuming could mean the difference between life and death. But fortunately for us today, advancement in technology have paved the way for a game-changing solution: point of care ultrasound, or POCUS. So in today's episode of Doctors Go Live, we're going to be talking to our very own consultant emergency physician all the way from Columbia Asia Hospital Tebrau, Dr. Christopher Hanjian Sheng, on the vital role of POCUS in not just saving lives, but from the front line of emergency medicine, but also to critical care scenarios and to bedside care. We're going to look into how POCUS is revolutionizing patient care in real time. Now, if you know someone who this information would be super useful, or if you think this is a really good topic to share with people and it's going to make a difference out there, please do share this video out on your social media, tag your friends, and follow us on our social pages as well, because this episode is definitely going to make a difference in their lives today. All right. So let's take a look at this video first.
In emergency medicine, every second counts. Traditional diagnostic method, they are time consuming, could mean the difference between life and death for the patient. Fortunately, thanks to the advancement of technology, POCUS, point of care ultrasound, revolutionizing emergency medicine and transform the way we delivered care. Hi, I'm Dr. Christopher Hanjian Sheng. I'm a consultant emergency physician at Columbia Asia Hospital Tebrau. Join me in the next episode of Dr. Go Live, when we uncover the vital role of POCUS, point of care ultrasound, in saving lives by empowering the emergency physician with real-time insight, enabling rapid decision making and improving patient outcome. Happening on Wednesday, 15 May at 3 p.m. See you then.
Welcome back. You're watching Doctors Go Live with me, Nina. If you've just joined us today, we're going to be looking into point of care ultrasound, or POCUS, and how it is revolutionizing patient care in real time. Wasn't that an amazing video just now? It makes me feel like, wow, we're in ER or something like that, right? All right, here to share with us how POCUS is empowering emergency physicians with real-time insights, enabling rapid decision-making and improving patient outcomes. Please welcome our own consultant emergency physician from Columbia Asia Hospital Tebrau, Dr. Christopher Hanjian Sheng. Dr.
Hello.
Sheng, thank you for joining us.
Thank you. Good evening, Nina.
Yeah, that was a really exciting video. You were like outside, inside, you could feel the energy of the emergency department. So yeah, amazing. All right. So before we continue with the interview, before I forget, right at the end of the show, we have our Doctors Go Live quiz, where we've got some amazing prizes for you up for grabs. So you want to really listen to what Dr. Sheng has to share today, because you could just go home with some prizes. Now, if you have any questions as well, please feel free to type it in the chat and we will address it at the end of the session. All right. Doc, thank you so much for joining us.
Thank you for having me, Nina. Such
Yeah,
a pleasure to be here.
awesome. Okay, we're excited to have you here because it's not often that we get to speak about technology, and I guess the emergency department would be the first one to have it, right? And it's
Yeah.
really exciting to have you. So before we go deep into the topic, though, maybe could you help us introduce yourself and tell us your role as a consultant emergency physician, and how did you get into it? I mean, do you like go into the hospital and go like, I want to be an emergency physician, or you're just thrown in there, just wondering.
Yeah, sure. Okay. My name is Dr. Christopher Hanjian Sheng. So I actually started off my practice at Hospital Kuala Lumpur as a houseman. So during in the Hospital Kuala Lumpur Emergency Department, during my last posting as a houseman, I was actually attracted by emergency department services lah. At the time, we are kind of a national tertiary center, and then a lot of interesting case was coming in. So there was a lot of emergency medicine is all about what we always say that we treat everyone from the moment they are born until the right very moment before they are discharged to heaven. So everyone is our patient. And then
Okay.
it is interesting is because it can any injury, any kind of things, it can come through the emergency door. You will not know what will be coming at the day. It is like how to say a blinded chocolate box. You're not gonna know what you're gonna get. So that is the fun part of emergency department. So I was attracted by it during the time. Then after that, I was sent off to Hospital Pulau Pinang, where I served as the neurosurgery team. Then neurosurgery was interesting as well, a lot of procedures and everything. Then after that, I came back to Hospital Kuala Lumpur. And again, I was lucky that I entered back emergency department. So emergency medicine is kind of like in between, is a mixture of medicine and surgical and procedure and everything. We used to say this is an interesting part of the first 30 minutes of all specialty, because our main job is to resuscitate, optimize, and stabilize. So it's the most important, most interesting of the first 30 minutes when patient came to hospital. But at the same time, emergency medicine looks forward to collaborate with everyone because we are a team player. We do understand that we appreciate everyone's effort, from the nurses, attendants, doctors from different field. Everyone come together like a team, giving input. Together we solve the puzzle for the patient and helps patient's life. Then later on, I entered University Malaya as part of the Master of Emergency Medicine. And also throughout these 4 years, I went a lot of places for attachment, rotations. Because, for example, I even went to IJN, Institute Jantung Negara, to attach with the cardiologists to see how they perform their PCI, the primary cutaneous angiogram and everything. Because in emergency medicine, we are always focusing on creating the best working flow. The best way when the patient comes, we stabilize, send to where, do the intervention at the right time, right place, with the right personnel. So then the patient outcome will be better. And then emergency medicine talk about stroke alert activation, PCI activation, a lot of activation. When you talk about emergency physician, we are about building up the system, getting everyone in, talking about coding, drills, system, networking. Basically, we are like a networking physicians. Then we try to come in. But then also during my training in the Hospital Kuala Lumpur, there was this team, ultrasound, point of care ultrasound was introduced by the current head of department of Hospital Kuala Lumpur Emergency Department, Dr. Mahada, and team like Dr. Hidayah, Dr. Al-Zamani. They are very well all-rounded senior. They introduced the ultrasound to even medical officer. I was a medical officer at the time. But then we always say in medicine, things are led. We are not boss. We are all trying to be a leader. So we try to perform by demonstrating. So we can see that how our senior integrated all these services in the point of care into emergency medicine, and then bring good result, because they basically, with the point of care ultrasound, the whole treating processes speed up. And we can give diagnosis treatment faster. So we don't need to wait for radiology department. Not all the cases need to send to radiology department like last time. Because radiology has also moved to a new generation. They are going for another precision medicines. And then there are a lot of MRI, CT scan, take times consuming. So so for example, there is a very long layup, 20 patient need CT scan. How do you know which one you have to push first? But with ultrasound, with, of course, like emergency physician will always tell you, the first thing is a good history. With a good clinical history, you're already 60-70% there. With a good clinical examination, another 10-20% down the road. And with a good ultrasound, you tambah another 10-20%. So you're almost 99% almost there. Then you, of course, then with that kind of precision, you know where the direction you're heading to. You can talk to your counterpart, the radiologist. You can persuade them, please scan my patient first. Out of the 20 patients, one need to be scanned first. So instead of this patient waiting in line, basically we're helping the patient to cut queue. Either to the scan, and with the point of care, we can cut queue the patient to the OT as well, operation theatre. We can persuade the surgeon, take this patient to the OT first, because this patient he has this such injury. With point of care ultrasound, it's cut short. And also, with point of care ultrasound, there are certain life-threatening injury we can pick up on our own. For example, like cardiac damage, pneumothorax, we can pick up as well. We can do intervention straight. So it cut down the time to intervention as well. So that is where this point of care ultrasound came to attract me a lot. Then after that, after I was serviced and completed my specialist training in the master program in Hospital Kuala Lumpur, I was sent to Hospital Sultanah Aminah. This is also another tertiary, but in the southern side. This is a trauma center, so there's a lot of patients need a fast decision making to speed up for the patient's conditions as well. So this is where, with the support of my head of department, Dr. Amin, and also my state physician, Dr. Masai, they actually agreed to let me go to Hospital Ipoh to learn from Dr. Adi and team. So I did my fellowship of ultrasound, critical care and emergency medicine, ultrasound under Wing Focus Society. It's an international body that trains physicians to become a fellow and to perform point of care ultrasound. So Dr. Adi and the team in Ipoh is actually the representative for this international body in Malaysia to train all different physician, emergency physician. They even train internal physician. And nowadays, they even expand the collaboration with anesthesiologists for point of care ultrasound, because anesthesiologists also take it in to use in ICU, use in OT to come up with a rapid diagnosis and intervention as well. So after I completed my fellowship of Wing Focus under Dr. Adi's guidance, and then I obtained it from the society, the Wing Focus. It's an international interactive networking society. And then after that, I joined the Malaysia chapter. We have a local chapter called Success. The name is called Success. It's a Society of Critical Care and Ultrasounds as well. So I continued the training and networking to enhance my training together, because we believe that by sharing it out, somehow God will bless you. The knowledge and skill can be retained because you share with other doctors, and other doctors go and perform it with others on the other patient, and then the patient will get such service. So after that, when I joined Columbia Asia Tebrau, I met few of the ETU physicians here also doing the same thing, point of care ultrasound. Then in the emergency department, we are very lucky. Our management already ready the ultrasound machine for all of us to perform the point of care ultrasound. So that's my journey in emergency medicine and my journey with the point of care ultrasound.
Right. So you actually specialize in point of care ultrasound. I just assume that everybody does it, but I guess not. It's a specialty.
Yeah. It's a training because you will get a bit of credentialing, privileging, and training as well. But of course, we are trying to spread share the knowledge and skill with everyone, so that every doctors can perform it as well. Yeah, but with proper training and guidance. Yeah.
Okay, awesome. Okay, Doc, why is it important that we discuss about today's topic? What key takeaways are you hoping the audience can take home, or whoever's watching?
Yeah, because point of care ultrasound, one thing interesting is it can be performed just by bedside. Some people say it's an extension of our stethoscope. Some doctors in the US even they claim they replaced the stethoscope with portable ultrasound. So they came out with an ultrasound in the stethoscope form. So it's an extension of a clinical examination. But bear in mind, it is not a replacement of our clinical history and our clinical examination. That is our main chore duty. This point of care ultrasound is an extension, tambah that 10-20% of percentage. Medicine is about the combination of arts and science. And then we are talking about the probability. Which one will be the probability, the highest direction, then we will go for it with the direction of diagnosis. So what the thing that take-home thing is that ultrasound is already available a lot of places. For example, in the ONG clinic, they are using to scan the prenatal and natal.
Yes.
And if you observe nowadays, even the general practitioner, a lot of them are bringing ultrasound. Because it's also beneficial for the general practitioner, the primary physician, and emergency medicine. I give you an example. Last time, when a patient came in, fever with abdomen pain, right-sided, you do not know whether there's stone inside, whether there is appendix, or even is pyelonephritis, a kidney infection. So with history, of course, a good doctor always asks a good history. He roughly knows the diagnosis. And he examines clinical, he also roughly knows. But he just wants to increase his chances by another 10%. He put the ultrasound probe there. Then he can see roughly got stone or don't have stone. Then easily he can decide, oh, this patient needs an hospitalization, need this one. Then he can pursue the patient, and then he can pursue also for the admission. So he can facilitate as well. Because seeing is believing. You can even demonstrate to the patient, oh, here's the stone. Then straight patient will just follow you. Okay, I'll go to the hospital now.
Okay, sounds fantastic, Doc. All right, so Doc, before we ask like what exactly is point of care ultrasound or POCUS and how it differs from traditional ultrasound methods, I guess we won't be able to understand that without first understanding what happens in an emergency department first, right?
Yeah.
So I guess before we find out what POCUS is, what happens in an emergency situation, and can we have the slides as well?
Can.
Okay.
All right. So, Nina, I can start to share with you all the process at the emergency department.
Yes.
All right. So, when a patient comes to emergency department, first of all, we'll do triaging. Triaging is a French word for sorting out. For us, the emergency medicine, we always want to sort out. It's like the traffic light. Who is the red? Who is the yellow? Who is the green? Because this is resource distribution. If you are red zone, you will get the attention immediately stat. If you are yellow zone, roughly around 30 minutes, medical care will arrive. The medicine care doctors will see you in around 30 minutes time. But of course, when we have the manpower, we'll do it as soon as possible as well. But if you are tracking to the green zone, then you'll be waiting around 90 minutes. So that is where, for an emergency department, triaging is very important because it's sorting out. It is deciding what kind of resources to distribute to the patient. Then after we sort out, then is the registration. As usual, we need to get the patient's information as well. After that, this is where the patient comes into ED. I take an example of maybe a red zone or yellow zone patient. Red zone patient, if they triage red, they will arrive immediately to the red zone bed. Then the doctors and the nurses, all the medical assistants will attend that. When we call that, it means immediately. So attend immediately, then we put on vital sign, we call it consultation. In all other doctors, we call it consultation. But for emergency, we like to say we ask focus history, short pertinent history, because emergency medicine is a bit different from other medicine. Other medicine, their patients are stable. They can get a lot of time to ask the full history. So for emergency medicine, patient already emergency, we can only choose a certain information, a pertinent information to ask. So we call it focus history. And then we will take the vital sign immediately as well to see the patient. Then after that, we will move into examination. Again, clinical, we always say about clinical, focus clinical history. So after that, you will see that we will take a lot of blood tests. Everyone says, come to the hospital, she got to take blood one. This is where the part happened. So In emergency medicine, we got a lot of point of care blood tests. So it's point of care. Why is it called point of care? Because emergency medicine, it moves fast, rapid decision. For example, what kind of point of care blood test we're talking about? Dengue. We will take a blood to check dengue serology, NS1, IgM, IgG. Is it positive or not? Then we will know, is this patient having dengue or not? COVID test, swab, then we will know 50 minutes, 30 minutes, whether the patient COVID positive or not. So this is called rapid test. We even have rapid tests, for example, like to see heart failure, pro-BNP, we call it. A lot of tests, a point of care test. So that is where imaging, last time we only have traditional conventional imaging, where they send to the department to do chest x-rays, and then we have to send to a department to do CT scan. But when you are working in a high workload hospital, you will see that your patient, even from red zone, they will take a while to line up. So this is where our concern for the patient comes in. So what can replace, make it faster, the work process faster? So we came up with the point of care ultrasound. We use ultrasound to kind of like screening product and also to facilitate things, to enhance to the decision of either OT procedure or even to the definite imaging. It's a tool to make it faster. Of course, in the ED, there's another point of care instrument that's very popular called ECG. You'll get it on the spot also. We can see it on the spot. No need to wait for send to cardio lab and then come back. ECG also is considered point of care test. So if you can see that emergency medicine likes emergency physician especially and the team, the doctors, emergency doctors, all we like fasting, point of care, point of care, and point of care. Finally, the treatment also must be fast as well. So we will always set drip, give fluids if there's no contraindication, of course. By clinical exam, if the patient is having heart failure, we're not going to give fluids. We only give patient fluids and medicine according to their indications and procedure. Emergency medicine, for example, if the patient, we already know that patient have pneumothorax, then we have to put chest tube in fast. We're not going to wait for it, especially if it's a life-threatening pneumothorax, the blood pressure is crashing, heart rate is crashing, everything is crashing. Then that is called life-threatening saving procedure. The emergency team have to perform it. We cannot wait for other team to come abroad, of course. But then, if the patient can wait, for example, like green zone, yellow zone patient, of course, we will get in the other team. Then we will discuss, okay, this procedure need to be done at this time or not. So in emergency, we always have this concept, whether this procedure can wait or cannot wait, we have to decide. If it's life-threatening, there's no waiting, no discussion, we do according to the protocols, do the procedures as well. So there's a lot of invasive procedure ongoing in emergency nowadays. We are doing pericardial synthesis, we are doing chest tube insertion, we are even doing the central venous line insertion as well. But so to reduce the complication, we are now moving to imaging assisted procedure. So with ultrasound guided pericardial synthesis, ultrasound guided chest tube insertion and everything, you can see on the time slot where is your needle going. It's like you having a waist in your hand now. The doctor have waist. We know where our
Google Map.
A map, yes, a map. We're having map now. Last time we only go by clinical, conventional method is by anatomical. What we know from the textbook, this structure should be in this position, 9 o'clock. But the problem is, the general population have a lot of variety. It's just like human characteristic. All of us are different. So whatever we learn in the anatomy textbook says that 60-70% the structure is there. But there's always 20-30% the structure can be interoperability is somewhere else. So that's why sometimes when we do invasive procedure, complication happens. But with ultrasound, you can see exactly like a map, like a waist is exactly hitting that place. So it avoided a lot of complication for us as well. Then last of all is the outcome. That is where the emergency doctor, like either we manage to reverse the condition, stabilize it, reverse the life-threatening, we save the patient, then we can admit to the ward. Or best, the patient in the green zone one, we see already no life-threatening, no organ threatening, can wait for another appointment for another consultation, the green zone, then we discharge. But of course, yellow zone, most of the time we will admit because yellow zone also need further workup as well. The green zone patient is the one that mostly we can discharge. provided there's no things that threaten organ, threaten the life. Yeah.
Okay.
So this is where, again, the slide shows the examination. It's always clinical, blood tests, and imaging, and also the point of care, like ECGs and instrument as well. So yeah.
Okay. And this one
So,
are the options.
yes, the imaging option. Let's talk about the imaging options.
Okay.
So in the emergency department, we can send the patient to x-rays. So the portability is not there because the patient had to move out. The x-ray cannot come. Can come, there is something called portable x-ray, but it's very difficult. You have to wait a certain period because the staff have to settle everything. Then Baru can bring the portable x-ray to the emergency department. And then bear in mind, in the red zone, you have different type of patient. So the x-ray imaging can affect the other patient that next door that doesn't need the x-rays. For example, if you have a lot of pregnant ladies, so coincident in your red zone, and then this patient is having shortness of breath, you're not going to order the portable x-ray for this patient. There's a limitation to it, because you will expose the patient to this one. But of course, you can do a bit of, but the portability is just not as good as ultrasound machine, because ultrasound machine is just bringing beside to the patient, bing, reach. This portable x-ray, you need few staff to push the machine out of the radiology department to reach to the ED. Then we talk about radiation. Radiation, of course, x-rays, there's radiation, but it's not as high as CT scan. And then whether it's easily reproducible? No, it's not. Why? Because 10 o'clock, you order the x-ray, then you send the patient to x-ray for chest x-ray. At 10:30, you order again the chest x-ray, you will get a phone call from the radiologist. Hello, why you repeat the chest x-ray so frequently? Or even you put 11 o'clock, maybe the radiologist start writing an incident form to the Pengarang hospital, the hospital director, saying this emergency physician is doing what? Because it is not in their practice to order as that frequent. So therefore, the next item is not dynamic because patient condition changes. I might need the information, what is happening in the lung from 10 o'clock, 10:05, 10:30, and 10:45. But x-ray, one slide x-ray done at 10:25 cannot tell me the information of the lung that is at the 10:55. Stuff like that. So dynamic is not there. Of course, there's cost. And then the image. Okay. And then bear in mind, x-ray, the portable x-ray versus the original x-ray inside the radio department is different. The quality is much more lesser for the portable. So that's why every time we want to order portable, we will think twice whether it's worth the benefit or not. Okay, let's talk about CT scan. Again, CT scan portability is not there because the CT scan cannot come to the patient. The patient must go to the CT scan. Okay, and then the radiation is higher than the x-ray because CT scan is built up by few thousand slides of x-rays. Yeah. So is it easily reproducible? Definitely not. X-ray 10, if I order 3 times in 1 hour, I will get an incident report. CT scan, same thing. I order 3 times, my name will go up straight. Dynamic, there's no dynamic. Cost, there is cost, it's more expensive. You need radiographer and radiologist interpretation. So you need a lot of people to manage. Image quality is better. Then let's talk about MRI. Again, same thing. MRI, there's no portability. You must go to the MRI. Radiation, yes, there's no radiation. Is it easily reproducible? No, because again, you cannot order MRI. And one MRI takes around 30, 40 minutes, like that. So you're not going to repeat it to this one the same day as well. Dynamic, no. Cost, yes. Image quality is good, 3-star already. Okay. Now, finally to the ultrasound. Ultrasound win where portability is can come to the patient. Radiation, there's no radiation. Easily reproducible. Why? 10 o'clock, I want to scan the patient one time. 10:20, I want to repeat, can. 10:55, I want to repeat, also can. So I can repeat as much as I can to get the information I want. So it's very dynamic monitoring. It's not costly, but you just need to buy that one machine that you can use for all patients. Image quality. Of course, you cannot compare the quality with MRI and CT scan. But then again, we are using the ultrasound to answer the question yes and no. We are not aiming for precision. We are aiming for binary questions process, yes or no only. So it suits our targets. So that's why ultrasound is a good tool for us to use in emergency itself. Yeah.
Okay, got it. I guess that brings us, what exactly is point of care ultrasound and who actually performs it?
Yes. So we can go back
Yes.
to this slide. Point of care ultrasound, also known as the after this slide. Yes.
Okay.
Yes, this one. Point of care ultrasound, also known as emergency ultrasound. Because it defines the situation. Only emergency, you bring the ultrasound to the patient side and you scan it. So it's also called as emergency ultrasound. Or it's also called as physician performed ultrasound. It's either by the emergency physician, internal physician, or anesthesiologist, or intensivist, ICU physician, or any physician that is inside their own department. Just bring the ultrasound to the patient to answer their clinical question. So that is why number 3 is also called focus ultrasound. It focus on something. We want to know whether there's bleeding in the abdomen, yes or no. That's all. I do not want to know what is the size of the liver, 20 cm times 16 cm, something like that. No, I do not know. Focus. I just want to know whether there's bleeding in the abdomen in a trauma patient. That's all. So it's called focus ultrasound. And that's the name. It's called bedside ultrasound. It's performed by the bedside of the patient. But then again, limited ultrasound is not going to tell you how big is the liver, how big is the spleen, how big is the gallbladder and stuff. So you just can answer a certain question, whether there's fluids in the abdomen, whether there's blood in the abdomen, such thing. So that's why it's also called as limited ultrasound. And then this is who, yes, why? We only do it when emergency. Who? Physician do it. Where? Bedside. When? Anytime. You can repeat it anytime, provided other people don't run past your ultrasound. Because now it's very popular. Everyone wants to do it. So everyone will say, hey, hello, my turn. I want to scan my patient. What is the thing? Is the focus yes or no? Whether patient got bleeding in the abdomen, yes or no? And how? It's real time, it's dynamic. Dynamic means that when I do procedure, I can even see the needle on my procedure is called dynamic, moving towards where. So this is called dynamic monitoring.
Okay, got it. Thank you. That was very, very clear. So, Doc, what about what's the difference between the traditional imaging kind of traditional ultrasound and point of care ultrasound?
Okay, let me share with you what is the working process when we do point of care ultrasound. Yeah, sure. So first, the doctor will just bring the ultrasound machine, put the probe on the patient. We get the image first. Then after that, we interpret the image. And then we collaborate the information into our clinical decision, to our algorithm to make a decision. Okay, for example, a trauma patient comes, we put the probe on the abdomen, we scan, we get the image. Then from the image, we will decide whether the image, there's bleeding there. And then if there is bleeding there, and then we will put this bleeding information into the patient clinical scenario. If the patient vital sign is not stable and there's bleeding inside the abdomen, we will call out the surgeon and ask the surgeon, do you want to consider to take the patient to the operation theatre as per standard of care? Because they can actually already got evidence that this patient have bleeding in the abdomen. Then patient is not stable, they have to take to the OT as soon as possible. And then next slide, I can show you what's the difference between the point of care ultrasound and the conventional conventional ultrasound and the imaging department. So as the name suggests, ours is called point of care. Theirs is called comprehensive. So you can know. Theirs is very good, very detailed. So a lot of people will say, Alamak, are you guys competing with each other? Actually, the answer is no. We are not competing. Our target market is different people. Our targeted population also different. We are complementing each other actually. Why? Okay, let's see. Point of care ultrasound is ordered, performed, interpreted, incorporated into patient care by one person. Tapau lah, basically. Yes. Emergency physician and emergency doctor tapau everything. He order, he perform, he interpret, he incorporate. But if you want to do a comprehensive ultrasound, the emergency physician have to order first. Use computer, order ultrasound. Then someone need to push it to the ultrasound department in the radiology department. After that, the tech guy will perform. Then after that, the interpretation, the report will be typed by the radiologist. And once the result out, the emergency physician will put it in. So you can see the working process is so long. So you can see the queue again. The queue will be very long. If everyone with abdominal pain, chest pain, shortness of breath, they have to wait for the ultrasound, even the comprehensive ultrasound in the emergency department, or even with now they can order CT scan of the lung, CT scan of the abdomen, but it's going to be time consuming, it become very long. So point of care ultrasound, by putting the probe, hey, I already, plus my history, by my examination, I already 80-90%, I already know what is happening with this patient. So I just pick up the call my radiologist, hey, I'm sending this patient in faster, no need to observe. Because last time, before this point of care ultrasound happened, the radiologist will filter. They'll say, this one no need to do first, you observe in the ward first. Take few hours, patient not responding to your treatment, then we will do imaging for this patient, either ultrasound and CT scan. So this is what they can cope because they have very good business. Radiology having a good business, long line of CT scan, long line of imaging, long line of ultrasound. So they will tell the physician they're treating, okay, you give treatment first, then we will filter later on down the road. But now, with point of care ultrasound, again, you can jump ship now. The one fellow, the emergency team, we scan, we know already, 80-90%. Then we tell our friend, the radiologist, then they're also happy to cut queue, then put, then the result come out also positive. Then they can answer, if anyone not happy why I cannot cut queue, they can answer, this one, very high risk, very high probability is this diagnosis. So this is where the point of care ultrasound come in. And there is anywhere you can perform bedside, in the ED, in the internal ward, and everywhere. Okay, next slide.
Next slide, hang on. Did you get it?
So before that, this one, So this is where also the clinical useful information in real times. What do you mean by real times is that it happened at 10:45, this patient got bleed, I know got bleed, I scan, I can record in my ultrasound machine, it's documented. Because there is something called as delay presentation of hemorrhage. There are some patients, after they're having an accident, trauma, they come to ED, they're having symptoms. But initially at 10:45, we sent them for CT scan, there was nothing. There was no bleeding. Because the bleed is too small. We call it very small bleeding. And then slowly their condition not improving, and then few hours down the road in the ward, maybe 10 hours down the road, then suddenly their pain become unbearable, their blood pressure drop. Then we send them to scan again. Then we saw the bleeding. So this is sometimes we call delay presentation of bleeding. So if you do not have this bedside ultrasound scan, it's going to be difficult to put faster the queue. Because people will say, hey, he already received his scan, should be other thing, wait for it. But if you have a bedside ultrasound scan, a few hours down the road, when he start to pain back, and then his vital signs start to come back, you just put the probe there, you capture the image, there's a bleed there. You call your radiologist, straight will go to the radiology department to get the CT scan, repeat again, no question asked. Or even sometimes if it's really not stable, they will go to the OT, operation theater straight. So that is where the clinical useful information in real time. But for CT scan, you must remember when they go a lot of things, then the technician, they perform, then the radiologist must prepare the report. Imagine when there's 20 reports ahead of CT scan.
Yeah.
Yeah, right, Nina. So the radiologist also have to take time to report, because his or her reporting is very important. Will decide life and death as well. So he's going to be very cautious. So it will take hours or even days to get the reporting. Of course, nowadays they getting more radiologists, so it's in hours lah. But then with ultrasound, you can get the answers sometimes even fastest. Okay. Then machine travel to patient. That is the benefit. The machine, and then it's simple working process because only one person needed, which is the physician, and also easily repeated for monitoring. So what do we mean by this is that, examples, when patient nowadays having dengue fever, we will give fluids to the patient. But some patient, after we give too much of fluid, then they will have, we call it fluid overload, too much of fluid, then flooded the lungs. Or patient deteriorated because there's something called plasma leakage. There's leaking from the blood vessels out, dengue. Okay, last time, fluid overload or fluid flooded only can pick up by chest X-ray. Okay, so first you imagine you give fluid, then patient become not well, then you have to wait for the queue to the chest X-ray, then you do not know for exactly what is happening with the patient, then you do not know you want to continue the fluids or you want to cut down the fluids. There's no tool to help you to make decision on the spot. But with lung ultrasound, we can do fluid assessment, we can scan the lung, we can know whether the lung is flooded or not, then we can decide our fluid regime. And even when the patient is deteriorated, 1 hour later, we can even just repeat the ultrasound to see whether plasma leakage or not. So this is called easily repeat for monitoring. For example, patient come in dengue fever at 10 a.m. First scan, ultrasound scan, there's no plasma leakage. Good, excellent for the patient. But at 10:45, suddenly the heart rate go up, the blood pressure crash. Patient say got abdominal pain. And then if it's last time, then you want to wait for CT scan and the conventional comprehensive ultrasound. It will take hours. Then you do not know whether you want to fluid resusc now or not. Then again, or if you take a decision to fluid resusc can in a blinded situation. But then with the ultrasound, it's like a waste, just put the probe in. Got plasma leakage, got evidence. Then I can decide my management, my fluid regime, and also the disposition, either ICU or a general ward or high dependency ward, HDW. So again, when you have easily repeated for monitoring, you can cut queue for procedure, can cut queue for OT, cut queue for imaging, and even cut queue can help the patient to go to ICU even easier. You can tell your intensity, this patient every leakage very bad. Then we got evidence, we got objective evidence. And finally, point of care ultrasound in comparison with comprehensive ultrasound, it answers specific question, yes or no. Got plasma leakage, bleeding or no bleeding. But Nina looks at the other side of the comprehensive ultrasound. It takes hours to receive the result. The patient travels to the machine. And then it's complex and noisome working process. And it's very hard to repeat as the working process is time consuming. Nobody going to allow you for CT scan 2 times in an hour. Nobody going to allow you to X-ray 2 times in an hour. All right. And then the anatomical region is using predefined parameter and measurement to provide diagnosis. But then again, point of care is not here to replace comprehensive ultrasound. Okay, comprehensive ultrasound will give you all the organs, measurement parameters, and give you an exact diagnosis. So we are not replacing that. There are situations we still need to go for comprehensive ultrasound. But point of care ultrasound is here to help the physician to make a faster clinical decision. Yes or no, and what intervention we want to give based on that yes or no clinical question. Is there a bleeding? Is there a bleeding? If there's a bleeding, what are we going to do? That is the point of care ultrasounds come in.
Okay, got it. So, Doc, out of curiosity, is there a difference between the machines as well? Because out of curiosity, is there?
Very good question. Well, okay, you can imagine the radiologists have the advantage. Ultrasound started to use in the imaging department. Yes. They're looking for comprehensive ultrasound. So the ultrasound machine was initially built for them. So you can imagine the thing is not moving. So they want something fixed there. They do not look for something robust. All right. And then they want the image detail is so nice because they are comprehensive. They want detailing number, very, very nice. So they are looking for those software, very good imaging and as well. Of course, when we start learning off point of care ultrasound, we also learn from the radiologists. Then after that, we came into use, we practice ourselves, then we become a sub-branch point of care ultrasound. Okay, so you can imagine. Then after that, when a lot of emergency physician, internal physician, even anesthesiologists performing point of care ultrasound, the market is there already. So the company also smart. They start to build ultrasound machine tailored to the point of care ultrasound. So you can imagine the machine, what will be the difference? The point of care ultrasound machine will be robust because it's to the patient, not bring your patient to the machine. So the company nowadays, they build for us the point of care ultrasound, which is robust. The imaging detail is getting better and better, but then we want something that is multifunction, different probes, can see different organ. Now we are going for poly organs ultrasound machine. We want to see the We can scan the cranium, we can scan the airway, we can scan the lung, we can scan the abdomen, the cardiac, the kidney, the lower limbs, the aorta, and everything. Again, we are going for, so the probe also must be very robust.
Okay,
Can
got it.
tahan robust.
Okay,
Then the
okay.
imaging is, yeah,
Okay, thank you. I think that really explains it and gave me even more information,
sure.
kind of thing. Okay, great. Let's take a look at the next slide. Yeah. Okay, so I guess, Doc, what can you share with us? Oh, where have you guys used it and how has it helped? I think you gave a lot of examples, but if you have any more, please feel free.
Sure. So actually, a lot of people will be wondering, hey, what is this? Harnessing focus in critical care, but Dr. Christopher only talked about emergency department. All right. The definition of critical care is that the care given to a patient in a life-threatening condition. So that is where critical care actually started in emergency department, because life-threatening patient will come into the door of emergency department, and once we stabilize it, then we'll send up to the ICU. So the anesthesiologist and the intensive critical care physician will continue their critical care there. So people will be wondering, hey, where is the critical care fit in? So that's where today I'm going to focus to talk about point of care ultrasound in emergency department, because our patient is undifferentiated. Remember the traffic light I'm talking about? It can be a critically care ill patient, the red zone. It can be a semi-critical care ill patient, the yellow zone, or just your good old green zone patient, a real green zone patient, someone that need urgency but not like threatening lah. All right.
Okay.
So according to our American College of Emergency Physicians, they came up with a policy statement now. So they actually provided the information on ultrasound guideline, emergency point of care, and clinical ultrasound guideline in medicine. Okay. Where is this important is because USA is very insurance-based claim. So their college must come up with something proper. How's the usage and what's the evidence for the usage, so that when their emergency physician or their emergency doctor perform, they can claim about it. If not, US people, they're a bit fussy. They will say, hey, what is the evidence? Why are you doing it? But I think that again is important for consumer right as well. Patient right and consumer right. Because one day all of us will become patient. We will also want to know when the doctor perform on us, is it evidence-based? Is it clinically practicing a standard of care? So this is where the policy statement is very important, because they will gather all the evidence to perform, to demonstrate to the world, this is the standard of care. So as you can see, the policy itself will talk about introduction, scope of practice, the training and proficiency, the credentialing, certification, quality management, value and how to reimbursement, and leadership and future issue. So the point here is like this, because if you don't credential and provision well, what will happen is, not to say they will be wrongly interpret result, and then it will bring harm to the patient. For example, there's actually no bleeding in the abdomen, but an inexperienced operator put the probe and declare there is bleeding there. And then suddenly everything changed. All the clinical management changed. Or even worse, there is actually bleeding in the abdomen, but the inexperienced operator put the probe there and declare there is no bleeding. Then everyone is happy. Hey, okay, we put the patient one corner and observe. But actually the patients keep on bleeding. So this is where the credentialing and provisioning is very important, to make sure that everyone get the same training and come up with the same result and give the patient the standard of care.
Okay.
Then the next slide would be the that next slide will be the role of ultrasound, point of care ultrasound in the emergency department. The number one resuscitative is the critical care. Resuscitation is critical care, life-threatening condition patient. And the role of diagnostic, whether this dengue patient got plasma leakage, which this trauma patient got bleeding or not, whether this patient have pneumothorax or not. And then number three is procedural guidance. So as I say, we do pericardial synthesis tapping, we do pleural tapping, we do CVR line insertion, and nowadays emergency medicine moved to regional block as well. We are giving a needle into the patient and release locally painkillers, okay, like lidocaine as well. All these considered invasive procedure, so need ultrasound guidance.
Okay.
Of course, there will be situation that doesn't need ultrasound, but it will be stated in the statement. But most of the time, we will follow the standard of care. And also, symptom and sign based. For example, nowadays, if you have shortness of breath, you come in, we will do clinical examination, we will do clinical history, and then we will scan you to look for the causes of shortness of breath way before even we send you for chest x-rays. Even some countries, they already start to accept that if you can scan and shows that there's pneumonia, you do not need to send the patient to chest x-ray to confirm it. But it's different country to country. Like in Malaysia, we still need to send for chest x-ray, although we on ultrasound we already know that it's pneumonia as well. Okay, where is this best demonstrated? Remember COVID?
Yes.
COVID, a lot of time you see some people wear the PPE, the white color PPE, there are a lot of people standing there. Then we'll put our probe there, ultrasound probe. I do not know whether, I think maybe some people that went through that process still remember. So whenever the shortness of breath, when we put the ultrasound probe there, we are looking for the causes of shortness of breath in the COVID patient. Because it can be pneumonia, it can be pulmonary embolism, it can be a lot of causes, it can be the cardiac causes. But putting the ultrasound probe can let us know, okay, based on this symptom, what is the most probably causes? And also during the COVID, we use the ultrasound probe a lot to prognosticate. We will decide, there's a scoring system. If this lung are already this bad, okay, we have to send to the hospital. It's not this bad, we can keep in the healthcare center. Remember, we got this COVID center to keep all the patients. So it helps us a lot the time the ultrasound, because we cannot afford to put CT scan, ultrasound machine, that kind of center. We only can use ultrasound machine. But of course, you cannot compare us with China. China, we know that they utilize a lot of CT scan because they have a lot high number of CT scan machine. But before that, China also uses a lot of ultrasound machine at the time for their COVID patient as screening tool. Because again, you're not going to send everyone to the CT scan straight. Too many line up. So they also screen first. So this is where the screening, sign and symptom, the usage of point of care ultrasound. Last of all, is therapeutic. If say we scan the patient, we think the patient has pulmonary embolism, then we can call up the radiologist to speed up to do the CTPA. That is the gold standard of imaging. But they want a lot of radiation. So without good evidence, right, radiologists very hesitant for you to proceed with CTPA. But with ultrasound nowadays, we do not meet such resistance. The radiologist is so happy. They say, wow, you really got evidence. I put the patient into the CTPA. Once the CTPA out, confirm the patient has pulmonary embolism, then we will start treatment fast. So the treatment process will be shortened as well. So this way, you can see in the American College, right, Nina, the core application is so many organs to scan. Aorta, bowel, intestine, cardiac, deep vein thrombosis, the eyes, pregnancy, and then even skin, soft tissue, testicular trauma, nerve block, urinary tract, everything. So nowadays we call it the multi-POCUS ultrasound.
Yeah, definitely. A lot of things to scan, right? Okay. Well, Job, just to share, like before POCUS, what was, say, the average time to treat a patient? And now with POCUS, how much time has it reduced? Just wondering. Yeah.
Okay, I can give a very good example on, there's something we call pulmonary embolism. Last time, when a patient having a pulmonary embolism, first the emergency doctor will see, okay, then we will do chest x-ray. Then after that, we will suspect, we have a scoring system, then we suspect pulmonary embolism. Then the emergency doctor will try to call the radiologist. Then the radiologist will say these golden words, please refer to your physician first, get a second opinion. If both of you agree this is pulmonary embolism, I shall proceed. So then the physician will come, will cut back again the patient, ask the history, examine again, and then thinking, I agree with you, emergency team. This could be a pulmonary embolism. But then again, patient, most of the time, they don't come in with one problem. They can come in with infected conditions. They can be having a pneumonia and a pulmonary embolism at the same time. Okay? Then there will be the threshold where the physician or the radiologist will say, okay, guys, looks here. Scan machine is full. We give the patient some antibiotics. We give patients a bit of fluids. We observe first. See patient responded or not. If patient responded, all right, fine. It's not pulmonary embolism. It's just a pure good old pneumonia. No need CTPA, okay? It's a CT scan, but you can see the pulmonary embolism. So you can imagine the timeline there. Then finally, patient not responding to the therapy. Then they decided, okay, let's call up the radiologist again. Let's go for the CTPA. Okay, but I don't blame the radiologist, because the radiologist also look out for the patient, because the CTPA, the radiation risk is very, very high, and also there's contrast as well. The patient can get allergic, the patient can get injury at the kidney, contrasted injury. So the radiologist is doing their job as well. They are trying to protect the patient's welfare. So goes with the internal physician. But nowadays, with ultrasound,
Go straight.
yeah, it's easy to persuade everyone. With ultrasound finding, you see there's right ventricle straining, there's 2-point compression test positive, and then with the history, then again, I have to emphasize on the history. Later, my junior get the wrong idea. Patient come, bring ultrasound. That is a no-no. It's always patient come, ask a good history. You will go in the right direction, 70%. Clinical examination, 10-20%. Your ultrasound is another 10 to 15% down the road. So a good history, you know this patient is pulmonary embolism. Good clinical examination, you know this patient is pulmonary embolism. Then finally, you need the ultrasound machine to persuade your physician counterpart. You with that machine, sometimes your physician trusts you. They say, okay, I agree. Let's go for the CTPA together. So then you call your radiologist. Now it's a team effort. Whole hand, 3 people sharing the same responsibility. Emergency physician say there's a pulmonary embolism. The physician thinks there's a pulmonary embolism. So if you are the radiologist,
go for it.
Go for it, friend.
Yeah. So last time, I guess there was a lot of time, guessing and whatnot. So it's really cut things short.
Yeah, things short. And then so when the radiologists, they also in the mind, they're thinking this could be a very high likely radiologist pulmonary embolism. So instead of a lot of the 10, 20 CT scan report, they will report this first. And then sometimes the physician or emergency physician will even go to the CT scanner, just stand beside the radiologist, not to say pressure, but friend and friend. Say, hey, can you give me faster result? Then we'll look together, discuss, because we want to give something called thrombolytic therapy. If there is really a pulmonary embolism, if it's indicated. Not all the time. Pulmonary embolism also got their category. Some, they just receive anticoagulant just fine. But some really needs a faster therapy of thrombolytic therapy. That will involve a cardiologist as well. So you can see that nowadays, medicine has become very complex. It's no longer straightforward. It requires a collaboration of multi-team discipline. So what is the tool to bind everyone together? Because there's already an objective result. Point of care ultrasound, I would say.
Right.
To speed up everything. Yeah.
Got it. Okay, let's take a look. So this one is other users or POCUS in other care?
This is what the society, I remember I told you the local chapter of Malaysia, the success, the society, they produce this COVID-19 pneumonia lung ultrasound guidelines. This is for the doctor's usage. So there's scoring system. How do we know whether patient deteriorating? What is the finding? So it's all about standardization of care. Because we doctor, we want to do something that other doctor can reproduce the same result. Because you never know when you will be at the other end of the patient. You could be doctor today, tomorrow you'll be the patient. So actually we are thinking ahead for ourselves also. We want the other doctor to give us the same ultrasound quality as well. Yep.
Got it. Okay.
This is where the potentially useful POCUS application.
Okay.
In COVID-19, what kind of scan we are doing? We can scan for identify whether patient monitoring, whether deteriorating or not. Remember just now the graph in front, no need to show again, there's a scoring system. So we will know whether our patient is deteriorating or not. During the COVID time, ultrasound, point of care ultrasound was utilized a lot because you do not have the manpower to send the patient for the CT scan and everything. So a lot of decision was made by the bedside ultrasound. Respiratory failure, triaging, we can even decide this patient can come to this health center or need to go to a bigger hospital. Mechanical ventilation guidance, when we titrate our ventilator, we can use the ultrasound to decide whether the lungs is opening up or not. Weaning off the ventilator. Then we can even know whether the organ dysfunction or not. We can scan the kidney, we can scan the liver, and then we can scan the heart, the lungs, see whether they are functioning well or not. And then we can do a lot of stroke diagnosis as well. The one's neuroimaging. And then we can scan for pulmonary embolism. As we recap back, one of the complications of COVID-19 is pulmonary embolism, thrombosis phenomenon. So this is where the ultrasound can help you to screen for deep vein thrombosis. And most important thing is nowadays we utilize a lot of fluids. Nowadays we call it's a drugs. To give fluids, you must give not one drop more or one drop less. So you must do your fluid status assessment using ultrasound and also your cardiovascular assessment, a basic one. We are not here to replace the cardiologist. We are here to complement, to see the question yes or no. We just want to know this patient heart good enough to receive the fluid or not. That's it. We're not like the cardiologist saying, oh, this WAF, okay, this one, the precise, they are comprehensive. We are clinical Christian. Is this heart good enough to receive the fluid that we are giving? So this is where during the COVID-19 time, the point of care ultrasound become very popular because everywhere you can't afford to send everyone to the scan room and MRI imaging. You just use the bedside tool that you have to come out with a rapid clinical decision.
Got it.
Yeah.
And this one, Doc?
This one is something that I would like to share with everyone because Malaysia is what? A dengue country, I would say. A dengue endemic country. Dengue is like everywhere, anywhere, anytime. So we have been using point of care ultrasound in dengue management a lot. This is a study from the Colombia. Actually, the point of care ultrasound, if it's in the trained hand, the image quality and also can help us to detect plasma leakage. Remember when I told you the blood vessel? The antigen from the viruses will hit the blood vessel and become leak. So it's like plasma leakage. So this point of care ultrasound can pick up this plasma leakage and pick up ascites and gallbladder wall thickening. Because once the patient, a dengue patient has a plasma leakage, the whole clinical management change. The scenario, the prognostication change. Become also same time, green, there's red light dengue patient, yellow light patient, green light patient. The situation change. But of course, last time we say we can use the good clinical history, good clinical examination, and vital sign charting to pick up all this. But it's a lot, involve a lot of people, involve a lot of continuous time, effort, right? But by putting the probe there, you will know, I got plasma leakage or don't have plasma leakage. Yeah, so that's why. So now we are promoting a standardized dengue protocol and training program in Malaysia as well. A lot of the major emergency department in the Malaysia and also in the district, they are utilizing this point of care ultrasound in dengue.
And this is to do with dengue as well?
Yeah, this is an example where we're going to scan. Just in case one day you come to the emergency department or any of us come to the emergency department, then the doctor tell you got dengue, want to scan, then suddenly touch here, touch there, then you go back, you're not happy, put Facebook. Hari ni doktor tentu saya sini sana. Sometimes, but so I just want to let you know that, we are scanning all these parts to try to see the plasma leakage. So you can see there's the marking there, there's the place of plasma leakage.
I see. Okay. Okay. Got it. And this one is in trauma?
Yes, this is in trauma. Remember the point of care actually, initially we utilized before the COVID time a lot in trauma. And then after that, during COVID time, become multi-organ. We use in a lot of things. And then also in dengue as well. And then nowadays, we actually practically using in all kinds of clinical scenarios. So trauma patient, when they come, if they are unstable, you saw the word fast scan?
Yes.
The fast scan is the type of protocol that point of care ultrasound. This is the good part of point of care ultrasound. There's a lot of author in this world. When they do something, they publish it, they make it standardized, then they put the name according to what they want. So we cannot change. Like a trademark, register already. So it's called fast scan. All right, it's faster. Focus assessment of sonography in trauma. That is the full name. Nowadays we call it fast. So if the fast is positive, you can see the standard of care is that if it's not stable, it is positive, it's go to operating room.
Okay.
And then if it's fast negative, then you can take to the CT scan room. So it becomes life and death. You can change the patient fate. by sending, when you do a scan, you know already this patient need to go to the OT room fast. You change the patient fate. Imagine there's no fast scan last time. Everything they say is do the scan first, wait for it. Not stable, right? You give fluid. You stable first, but cannot. Some condition, the bleeding, you need to go to the OT. The surgeon must go in and stop the bleeding inside. It's not outside, it's inside. Yeah. So this is where that time we already see the magic of fast scan. It fasten up everything, save patient life. Because you see the algorithm become differently. Fast positive can go to OT straight. Fast negative go to CT scan first, then to re-examine by the surgeon later on. Yeah, it changes the fate.
Okay, got it. And this one are other uses, right?
Yes, this is the procedure that I'm talking about. So the ultrasound nowadays, we use ultrasound guided regional anesthesia. This is practiced by either the anesthesiologist, the intensivist, or the emergency physician who has training for this. We call it UGRA, ultrasound guided regional anesthesia. All right, it's a very popular concept nowadays because nowadays a lot of people don't want to. They just, you see, you have a cut in certain places. You just want to numb that certain place. You don't want to numb the whole body, or don't want, they get the complications. So we just numb the specific place, and then we give the local anesthesia, the painkiller at the specific place. But then again, you need to use ways to guide because neither injured other thing, they're not nice. Then same again, go with ultrasound guided pericardial synthesis. Ultrasound guided intravenous access. Here's this one thing that last time we used to pride ourselves. Wow, our line setting very good. When you come to emergency or any ward, everyone will set line, right? Give you a line, intravenous line. Yes. And then you will see, last time 1, 2, 3 times cannot get, still try, try. Then either you complain or you inside the heart scolding. Yeah, very painful, doctor. But nowadays, with the ultrasound, it's getting more easy. We try 1, 2 times the conventional way cannot get, then we'll get an experienced operator to come in, put the probe there, then you can see, can you see the needle? We can even see where the needle going in to the vessel, then park it exactly the place. So this is called ultrasound guided intravenous access. So it reduces complication, it increase, you can imagine, increase patient satisfaction and can make the patient a happier person. And also yourself, in your team. Yep.
Okay, Doc. I think this is the last slide, right? But anyway, these are all fantastic positives. Not to be the devil's advocate, but just wondering, is there any potential drawbacks of using POCUS, like any limitations or challenges? Just wondering.
Yes, there's nothing is perfect in this world. There's always challenging. Okay, so what the challenge issue that we feel is that, number one, we observe that there's a trend. Once you have a POCUS, then you don't take a proper clinical history. You don't do a proper clinical examination. You just strict scan. But the problem is, by only scanning, you just only get a 10-15% of the puzzle. And then based on the 10-15% of information, you already make clinical decision. So it's not fair for the patient. Again, the true process is a clinical history, clinical examination, plus POCUS. Then you get a very good 70 to 80% of proper information for the patient. This is number one challenges we observe throughout the trend. Number two challenges is that training, actually, credentialing and training. So we are trying to come up with a standardized training because ultrasound, there's inter-observer variability. Some people will say yes, some people will say no. So we are trying to standardize the training. So we want to make sure that the training is adequate, that everyone has seen together enough, then baru you give your clinical decision. Because you will make a lot of changes. For example, the patient with plasma leakage in dengue, an inexperienced operator go and put and say, oh, no plasma leakage. Then we send the patient to the normal ward with a normal monitoring. It will be very very bad condition for the patient. So that's why we are now looking into standardization, credentialing, and privileging for the process. We want to make sure everyone is on par to perform and to give good ultrasound scan, point of scan ultrasound. And finally, there's always limitation. Example, a very severely obese, morbidly obese patient, your ultrasound scan machine can't see very well actually. There will be limitation. So you have to acknowledge that limitation and document down and try to find other way. But what we scared is that sometimes you can't see well, right, in morbidly obese, but then because of certain things, pride or what, then you say, oh, I can see, then you put down your result, then this is not good for the patient. But nowadays, this phenomenon, we have been emphasizing it, then it has reduced significantly. So we already been telling all of us ourselves, even whoever experience, if you cannot see, just document down, you cannot see. Document. And then nowadays, everything is black and white. Why? Because we will print out the image or we will save the video clip in the ultrasound machine. Okay. So if anything happens, we go to meeting, we say, all right, let's show us the ultrasound clip. Okay. So this is where the college also recommended that you need to have a process of audit, pre-imaging, yes, to overcome all these challenges.
Okay, very interesting, Doc. Okay, since time is almost running out, one last question here, Doc. So if there's one message for the audience to take home about today's episode, what would it be?
Well, Nina, first of all, I have to thank you and the audience for all your time. So the message that I want to send out is that point-of-care ultrasound is anywhere, everywhere, and can be done at any time. So it can help to save life. So I hope that more doctors, especially in the primary care, they can join us in this effort to provide these services to the public out there. Because a lot of the GP clinic nowadays got ultrasound machine. We just need to come in together for the training, for the credentialing, privileging, and then we can provide the care to the patient. Then we can speak in the same chapter. And then the patient itself also sometimes can ask, I want to see the image. Sometimes also when I do, I can show the patient, this is the image as well. It's really interesting. You can see your own liver at the dynamic time, at the exact time as well. Yeah.
So I guess as patients as well, we can ask for POCUS because it is readily available. And thank you so much. Now I'm aware. Otherwise, I always think it's just for pregnancy. That's it. Yeah. Okay. All right. So since we are running out of time, thank you so much for the information. I thought it was absolutely amazing. So does Mei Lin Min. So we have a few questions, but in the interest of time, I think let's go to the quiz very quickly. Right. So it is quiz time. And as mentioned earlier, in the earlier part of the show, we've got exciting prizes for you. But what do you need to win? First, you got to be sure to share this video out at least 3 times. And remember to set the share post to public so everyone can see. And next, answer the 3 questions we're going to show you in a single comment or in a single line, and you're on your way to win prizes. So let me repeat that. Share this video out 3 times. Remember to set the post to public so everyone can see. And secondly, answer the 3 questions we're going to show you on the screen in a single comment, and we'll select the first 3 winners based on the correct answers and the shared post. So are you ready? Let's have the questions. So question number 1, POCUS can be performed by healthcare providers at the patient's bedside. True or false? POCUS can be performed by healthcare providers at the patient's bedside. Is it true or false? POCUS is considered an extremely invasive imaging technique. True or false? POCUS is considered an extremely invasive imaging technique. True or false? Last question is POCUS is primarily used for prenatal imaging during pregnancy only. True or false? POCUS is primarily used for prenatal imaging during pregnancy only. True or false? Please write your answer in a single line. All right. So while waiting to hear who our lucky winners are, let's go into the Q&A. All right. First question, actually the first one is not a question ya, Doc. Ini adalah fan. I rasa Latifah binti Zainal Wafi saying, hello doctor, selalu order fish and chip dekat cafe. So we know our doctor loves fish and chip. All right. Okay. So we have another question, Mei Lin Min. Tapi betul ke, Doc? You selalu order fish and chip?
Yes.
Yeah, all right. There you go. So if you guys are happy with that, you know what you can get here. Mei Lin Min is asking, what's the difference between traditional ultrasound with point-of-care ultrasound? I think you answered, but just very quickly, Doc, what is the difference?
Sure. So again, the traditional ultrasound is a comprehensive ultrasound, but it's not available at the bedside. You need to travel to it, and then it's a lot of working process, a lot of person involved, and then the report will get maybe hours or days later. And also the machine itself is answering comprehensive. It come up with an absolute diagnosis. For example, the size of the organ, how big it is there any lesion there, and stuff like that. But point of care ultrasound is to anytime, anywhere by the patient bedside, operating by one physician, and then is to answer clinical question, whether there's bleeding in the abdomen now, in the trauma patient, whether it is plasma leakage in the dengue patient now, in the dengue patient, or whether this patient is having a pneumonia now, yes or no. And then based on that answer, yes or no, we quickly give a clinical decision to give the treatment straight. So we don't need to wait for it, basically.
Awesome. Very, very short and padat answer. Thank you, Doc. Ainon's question, Ainon Nadira, is can POCUS be used effectively in ambulances or remote locations? Very good question, Ainon. Doc.
Very good. Actually, POCUS has been utilized in a lot of places in ambulance or remote location. For example, the best way to use POCUS is where it's on the oil platform.
Wow.
Because oil platform. For example, your patient having the worker there suddenly has injury of the leg. You do not know whether there's fracture or not. You can even use ultrasound to scan the bones to see there's disruption or not. So POCUS has been utilized also in the industry, oil platform, and in remote location. And then the best part is, once you use in remote location, for example, in the oil platform, the doctor already diagnosed this patient with that POCUS result, for example, got fracture or got abscess in the soft tissue. They can send the image to the tertiary hospital. Then they can arrange helicopter to bring the patient out from the oil platform. Because all this require resources. So now you already got evidence the patient need the care. Rather than before the ultrasound, everyone will say, okay, let's treat the other thing first, see the patient get better or not. Maybe not fracture, soft tissue only. Okay, let's wait for it. So with POCUS, now you can cut down the wait and see approach. You can got objective things, then you can send out. Yeah, because in order to people to pour in resources, you need a tool to convince them. And I think POCUS is a very good tool.
Yeah, amazing. Provided it's used properly. Okay, next question. How accurate? Another question from Mei Lin Milne. How accurate is the ultrasound report? Is the image clearer than conventional ultrasound? I'm assuming ultrasound report is for POCUS.
Okay, the POCUS ultrasound will only few things they will answer yes or no, and then how to use in clinical question. So if in the correct person's operator, for example, in the fellow, we have a fellowship of it, and in the trained personnel, the accuracy is very, very high. It's already proven in the studies in comparison with a fellowships versus those radiologists. There's a lot of study ongoing already. So the accuracy is high because it's performed by trained personnel like a fellowship fellow. Okay, about the image clearer than conventional ultrasound. We only need an image that answer yes or no. We do not need the super ultra clear image. But then again, because now they already market for point of care ultrasound, so the company, a lot of competing company from US, Europe, China, they are coming in with a lower price, higher image for point of care ultrasound imaging. So nowadays, even a very good one, the point of care ultrasound is almost as same as a conventional ultrasound. Some even better already.
Wow.
Yeah.
I guess to answer this question, it's kind of like, cameras, the DSLR cameras are like the conventional ultrasound machine, and your phone cameras are like the POCUS ones lah. And of course the phone cameras are getting better and better with technology.
Yes, Nina, you are absolutely right. It's about the market. Once there's market, the company will come in produce a better images. Yes.
Yeah, definitely. Okay, great question, by the way, Mei Lin Min. And final question before I announce the winner from Aino Nadira again. I think we spoke about this, but very quickly, Doc, are there any limitations or challenges associated with POCUS?
Yes, there's like I previously said, the limitation is that number one, we have to standardize the training, because the training, if it's in an inexperienced operator, can produce a devastating result as well for the patient. So this is the ongoing project, standardization of training program. And number two is that we do not wish to see the phenomenon where patient come straight ultrasound probe. Yeah, it's always good clinical history and good clinical examinations.
Okay.
Okay. Then number three is the certain patient body habitus like severely obese. Yes, it will limit your ultrasounds imaging. So you must know your limitation. Certain patient clinical condition also will obstruct the image. So this is where the training coming very important. We must know what kind of clinical situation it will limit what kind of image, what kind of limited information you will get.
All right. Okay. Thank you so much, Doc. Okay. Congratulations, you guys. We have found out who our winners are. But before we announce who our winners are, let's find out what the correct answers to the quiz questions, shall we? Do you have the right slide? All right. So the first question, POCUS can be performed by healthcare providers at the patient's bedside. True or false, Doc?
The answer is true.
Of course, we spoke about it, right? Almost
Yeah.
everywhere. And second question is POCUS is considered an extremely invasive imaging technique. What is the answer, Doc?
The answer is false. It's
All right.
non-invasive.
Yes. Okay. And finally, last question is POCUS primarily used for prenatal imaging during pregnancy only. Is it true or false, Doc?
Well, this answer a bit open to interpretation. If you ask an
Mm.
ONG specialist, he will say true lah. But if you
Correct.
ask an emergency physician, we will say false.
Yeah, because you
Because
say anytime, anywhere. Probably
multi-organ,
all
yes.
organs. Yeah, multi organs.
Yeah.
So the answer is true, false, false. All right. And the winners are the winners for the quiz are Fat Yo Yo. I'm sorry if I'm pronouncing your name right. Ara Deva Haran, congratulations, and Kate Mai. That's Kate Myy. All right. So the winners again are Fat Yo Yo, Ara Deva Haran, and Kate Mai. Congratulations. All right. So we have our winners. Thank you so much. Congratulations to our winners. What we're going to do is we're going to be contacting you after this within a day to get your details. So be sure to check your Facebook Messenger inbox. All right. If you don't check it, we don't know who we're going to send it to. All right. So thank you so much for taking part. Thank you so much, Doc. I've definitely learned a lot, and I'm sure our audience have learned a lot as well. Shall we give our doctor a round of applause? Yeah. Okay. So thank you so much,
Thank
Doc.
you so much. Thank you for everyone for
Yeah,
having me
thank
here.
you, thank you, thank you. I think definitely if emergency, I want to go to Columbia Asia Tebrau, but I think that's a bit far because I'm in Selangor, kind of thing. But anyway, if you guys found this episode really useful and if you love Dr. Chris, please share this video out. If someone could really appreciate all the tip, info, and insights from today's show. So please share the video out, tag them because you never know who it's going to make a difference to. And that's all from us today. Please take care of yourself and each other. I'm Nina and Dr. Sheng signing off. We hope you had a wonderful episode. Thanks.
Bye-bye.